So MRI-based navigation, that's not quite common because everybody uses 3D C-arms or pre-op CTs or intra-op CTs to visualize the spine. I have no disclosures, but the biggest disclosure is that I do not regularly use navigation for pediatric deformity surgery. Because most radiation exposure for pediatric deformity patients is from the pre- or intraoperative imaging. Actually, 1 in every 1,000 AAS patients that undergo navigation surgery will develop cancer because of the navigation or the imaging required for the navigation. And surgically treated AAS patients, they receive the highest effective cumulative dose and their cancer risk is about 50% higher than their peers. So every form of spinal navigation requires some form of 3D imaging. It can be either intraoperative 3D imaging or preoperative 3D imaging. But if you use pre-op 3D imaging, you need some form of referencing because that pre-op 3D imaging is normally acquired in a supine position. The patient is position prone, so you need to reference how that spine is positioned on the surgical table. You can use several methods for that. You can use point cloud surface matching, you can use the automatic surface matching methods, you can use fluoro image matching, or you can use patient-specific guides, which actually also are a form of 3D surface matching. But if you want to get rid of the radiation exposure, actually we do not have any imaging option left. And also the fluoro registration is not there anymore. So what are the alternatives? So there is MRI bone imaging. There are various ways to create an image of the bone via MRI. These are techniques that are similar to a filter on your smartphone when you take a picture. So that's black bone imaging, zero echo time sequences, 3D gradient echo sequences, and they create images like this, where you can visualize the bone. However, there is now also an alternative, and that is a synthetic CT generation based on an MRI image. So this is a 3D MRI RF spot sequence, and that is converted by an AI network into a synthetic CT. So the images on the right, that's not a CT, those are MRI images. And this is an example of how we now implemented our clinical MRI protocol. It is a total 14-minute scanning time. It includes a full spine T2 series in a sagittal scan, as well as a 42 centimeters scan of the thoracic and lumbar spine, where the input for the synthetic CT are the in and out phase images that you see as the second and the third image, and those are the synthetic CTs that are generated by the AI network. So what we did is to test if actually this imaging can also be used for spinal navigation. So we tested the safety and the accuracy of MRI-based synthetic CTs as the input for spinal navigation, and whether that is non-inferior to the conventional CT as the input. So those were investigator-initiated studies. Of course, we had to collaborate with some companies to test it. We used commercially available spinal navigation systems with the point cloud surface matching, because that is completely radiation-free. And we compared the preoperative MRI-based 3D synthetic CTs to conventional CTs. So we instrumented 5 cadavers from head to toe. We instrumented 230 K wires, half of them MRI-based, half of them conventional CT-based. We did it with an international team of surgeons with the 2 modalities and randomized each side and each level. This is what it looks like. So we instrumented the cervical spine, the thoracic and lumbar spine, and we only instrumented K wires, and later we placed vertebral screws over those K wires. So we saw no pedicle breaches more than 2 millimeters with any of the techniques in the thoracic and lumbar spine. Some grade B breaches, but those are considered clinically not significant. But when we compare the planned and the postoperative screw position in terms of accuracy, we saw that with this technique, the average accuracy with the CT system is about 2.4 millimeters with an error of about 4 degrees. And with the synthetic CT, which is MRI based, the error is similar. Also for the cervical spine, we observed more or less similar accuracy, around 2 millimeters, so slightly more than we would expect based on the clinical experiences, and an average error of about 5 degrees. We also did recently a cadaveric safety study where we actually created those 3D models, in-house printed and commercially available, based on the synthetic CT, so based on the bone MRIs. And there we just did the first analysis, and there we saw similar results in terms of accuracy, so no major breaches. So how do we bring this from bench to bedside? If you want to use spinal navigation with radiation-free 3D imaging, you can be very lucky, like the paediatric neurosurgeons in our hospital that have the intraoperative MRI. But I think that is not generally available for many people, and that will require multiple scans for the spine. So I think this is not the true solution for us. So we have to rely on the pre-op 3D imaging and use the intraoperative referencing. You can use the point cloud surface matching. We still have to see whether it also works with other techniques of referencing, but I think these options are now available. So the first step is that we have pedicle screw navigation, but I think it is also very important for pediatric deformity surgery that in the future we will get some live feedback on the 3D corrections that we actually do. And for that, probably we need augmented reality. On the left, you see the 3D reconstruction of the bone MRI that I showed earlier, and this is how you can implement those things, but this is still a future to come. So in conclusion, MRI-based synthetic CT combined with a conventional spinal navigation system is feasible, and it is non-inferior to conventional CT for safe and accurate insertion of pedicle screws in the cervical, thoracic and lumbar area. So radiation-free spinal navigation in pediatric spinal deformity is definitely something we should explore. Thank you.
Thank you, Tom. I think the very important point there was that most of the radiation in pediatrics is before the operation in a cumulative effect. And then that is a worrying situation still, even with the advent of EOS. Any questions from the audience, please? Yes, one from Prof. Meyer.
I don't have a question. I just want to stress that this is a very important work, because it is true that I just said cervical spine is different from thoracolumbar, but I accept the argument of all the dedicated deformity surgeons that you can't extrapolate from any other indication to deformity surgery, and there must be another solution. And I think if that works, and I don't see a reason why it shouldn't. I mean, 2D is an option, but I think nowadays, even with the AI that you have, the matching, the automatic matching would be feasible. This should be the way to go, because it's completely acceptable, especially if you do children, that must be something which needs to be followed.
So one of the difficulties is that this imaging technique has been validated from 12 years and older, but it's more or less impossible to validate it to younger children because you will not make a CT just for the validation of the bone MRI algorithm.
I know. But still, then... Yeah.
There's a question from Derek in the audience.
Yeah, do you see CT, do you see the opposite? Do you see a way to use machine learning to visualize stenosis on CT instead of having to use an MRI scan? Because obviously in some cases you can actually see on an ordinary CT, you can see stenosis, albeit shades of grey in the canal. So can you see a situation whereby we can project what stenosis looks like from a CT scan instead of using MRI?
Yeah, so we reason the other way around. We are now thinking of combining the two images. So combining the T2 images in the spinal canal with the segmentations of the bone on the synthetic CTs and fuse them into one image. That would be an option to visualize whether there are some neural compressions.
Tom, I just had another thought. You know, the T1 Vibe images in the MRI scans, aren't they not as good in quality as CT scans for the bony anatomy? So
this MRI sequence is a 3D series with a voxel size of 0.6 by 0.6 by 1 millimeter. So that is similar to the thin slice CT.
Okay.